First, I present you some slides from history. This is presented already a few times. Already during this meeting I saw it, and you know this paper very well, the Best Kidney Study. And that's probably the first large study on epidemiology of AKI in ICUs. As you can see, a very large study, almost 30,000 patients were included worldwide. And acute kidney injury was at that time defined as acute renal failure, and it was pretty much patients needing renal replacement therapy. Either they were oliguric or had an increased BUN. And the incidence of acute kidney injury at that time, using that definition, was almost 6%, and 4% of them were treated with dialysis. That was the early 2000s. Following that, we had the rifle criteria, the more sensitive criteria defining acute kidney injury. And as you can see, a lot of cohort studies, single-center cohort studies, found varying incidences of acute kidney injury using these rifle criteria, varying between 1 in 3 patients to almost 3 in 4 patients in the ICU having acute kidney injury defined by rifle criteria. And, well, the discussion were how can we explain these differences? And one of the main issues was that the definition was not used complete in all centers, and some used only creatinine criteria. There was an issue with the baseline, etc., etc. So that could be an explanation, apart from the difference in baseline characteristics. When we used the same definition in 6 different centers, and you can see the different centers, Vicenza was part of it, and centers in the US, Pittsburgh, Mayo, Hoste and Perth in Australia, and in Belgium, we contributed. We used the same criteria for defining acute kidney injury, also in a retrospective way, and we found, again, huge differences in occurrence rate of acute kidney injury, ranging between, I have to see, it's small prints, 56% and 85%. And there was also a huge difference in mortality, and this when we corrected, adjusted for comorbidity and severity of illness, etc., etc., this difference in mortality remained, so it was intriguing. These were all cohort studies using the rifle, KDIGO, AKIN definitions, and the next decade, the 2010, we entered the decade of prospective collected data. And the first that reported prospective collected data were the Finnish. They presented the FINACI data in 2013, 17 ICUs, almost 3,000 patients, and they looked for the 5-day incidence of acute kidney injury in their ICUs. And they found, using the AKIN definition, that almost 40% of their patients in the ICU had, during the first 5 days, an episode of acute kidney injury. And this was 746 patients per million inhabitants. And the incidence of renal replacement therapy 10 years after Best Kidney almost doubles. 9%, almost 10% of the patients in the ICU were treated with renal replacement therapy. So that's Finnish data. We and you contributed in AKI Epi, a worldwide study on the incidence of acute kidney injury in ICUs all around the world. And here you can see the units that participated, almost 100 units, 33 countries, 1,800 patients. And we found that in these units, 57% of patients had an episode of acute kidney injury during the first week of ICU admission. 57%. And if we, there was always, you will recognize that you never know on all of your patients the baseline creatinine. And when we selected the cohort of patients with known baseline creatinine, this incidence even increased to 62%. So acute kidney injury is a major thing in ICU patients. And it's not only the least severe forms of acute kidney injury that's so prominent, because 1 in 3 had AKI stage 3, and 13% were treated with renal replacement therapy. So it's not because of the very sensitive definition that we're seeing this high incidence of acute kidney injury. It's also the more severe forms that are more have a higher incidence. Not surprisingly, these patients have comorbidity or have organ failure at time of AKI diagnosis. 1 in 3 were mechanically ventilated, 1 in 2 had vasopressor support, 20% had an increased bilirubin, 20% had decreased platelet counts. That's all according to the SOFA score. And this is the etiology of AKI according to the physician, classified according to the physician. And these are, the orange bars are the data from Best Kidney, so the early 2000s. And this is the light orange bars are the AKI epi. And as you can see, not much has been changed in this 1 decade. Sepsis and hypovolemia are still the most prominent etiologies of acute kidney injury. How do AKI patients look like? I can show you some data. Not surprisingly, they're a bit older. They have a higher severity of illness expressed by a higher SEPS-3 score, and already some of them have acute kidney injury when they are admitted to the ICU. And interesting also, their reference creatinine, so their baseline kidney status, is indicating they already had some chronic kidney disease. The baseline kidney function is less. They have more comorbidity, especially cardiovascular and diabetes. Comorbidities are more present in AKI patients. And when we combined all comorbidities and etc. into a multivariate model, we found that hypertension, diabetes, cardiovascular reason for admission, and severity of illness were the factors that were independently associated with development of acute kidney injury. And for one reason or another, neurosurgery was preventive, but I guess that's illustrating that these patients probably were observed for 1 day or 2 days in the ICU after having elective neurosurgery. That's my interpretation of this. Kidney outcomes. As you can see, patients who had AKI, the light bars, had higher serum creatinine when they were discharged from the ICU and when they were discharged from the hospital. And when you translate that to eGFR, you can see that at time of hospital discharge, 47% of patients had an eGFR less than 60. And I know eGFR calculations in hospitalized patients are not that good, but it gives you an indication about the impact of an episode of acute kidney injury also for the longer term. They had a longer length of stay, AKI patients, and mortality was markedly increased, even when we used the very sensitive KDIGO criteria, as we did in the AKI EPI study, 7% for non-AKI patients versus 27% mortality for AKI patients. When we adjust for covariates, we find that AKI stage 2 and 3 are associated with markedly increased mortality. AKI stage 2, an odds ratio of almost 3, AKI stage 3, an odds ratio of 6. So 3 times as the risk multiplied by 3 or by 6 when you develop a serum creatinine increase by times 2 or times 3. It's enormous. And this holds true for different models we looked for. Interestingly, we also did, like in 0x25, looked at differences around the world, and we found that the incidence of AKI varied per region, and we did not have that many units contributing from Africa, so that's you can see also the confidence intervals, it's wide, but you can see there's a difference in incidence around the world, and also a difference in mortality around the world. And this is well, the previous were continents, and this is more distinct regions. Interestingly, when you classify countries according to their income, like 0 by 25 did, lower middle income, upper middle income, high income countries, we found that the incidence was the same in the different countries, and also mortality was the same. Interesting data. And when we adjust for all covariates, for severity of illness, age, etc., we found that the mortality was similar in all continents, in all regions of the world. So that makes you wonder. You would expect that in regions that are more privileged, the mortality would be less, because we are with more in the unit and we are doing our things to prevent development of acute kidney injury and to prevent mortality, but apparently it doesn't work. So either we are not doing things right, like they demonstrated in the UK, or maybe the things we are doing are not the correct things, and we need to look for different therapies for acute kidney injury. That's some of the conclusions we made. What happens after hospital discharge in these patients? Well, long-term survival is not good, and these are data from the renal study, from the Australian study on dose. You know this study very well, different doses of renal replacement therapy in patients treated with CRT in Australia, and this is 60 months follow-up data, so pretty long. And when I blow up this graph, you can see the mortality in this 60 months in the 90-day survivors. And you can see that 40% of these 90-day survivors died in the 60 months following their discharge. That's a lot. And what's the reason for that? Why are AKI patients having this high mortality after being discharged from the ICU? Well, there's lots of data have come out that suggest that these patients are at increased risk for cardiovascular disease. And that has been demonstrated in Scandinavia, but also in the United States. So, and depending on the severity of acute kidney injury, the risk for cardiovascular disease is increasing. So that's interesting. Why might that be? Well, there's also an issue with kidney function after discharge, after having acute kidney injury. And this is again from the renal trial. And they looked in these long-term survivors, and they measured their eGFR, their serum creatinine, and they measured albuminuria. And they showed that there was a marked decrease, and it's very fine print, excuse me for that, but they saw that 38, that there was a change in eGFR of 38, so a decline in eGFR of 38 in these long-term survivors, and intriguingly, 40% of them had albumin in their urine. And well, that's not a number we as ICU physicians are very accustomed to, but when you relate that to other databases, we find that, well, the incidence of albumin in urine is less than 10%. One particular study in Canada found 25%, but 40% is really high. So something happened to the kidneys of these patients. They developed chronic kidney disease. And this is a graph the nephrologists will recognize. It's how they classify their patients. And it's based on albumin in urine on the horizontal axis and eGFR on the vertical axis. And you can classify the patients on basis on the combination of the two components. And as you can see, over 40% of patients who survived CRT in the ICU in Australia were either in high risk or in very high risk for that or worsening chronic kidney disease, according to this graph. So 40%, that's a lot. And this nicely illustrates the interaction between acute kidney injury and chronic kidney disease. Patients who had acute kidney injury are at greater risk for developing chronic kidney disease, and that is probably not very well recognized in our patient cohorts at present. And we all already know that it also works the other way around. Patients who have chronic kidney disease are at increased risk for developing acute kidney injury, and also are at increased risk for developing worse outcomes on the long term. And this is a graph from Sweden, but there's others like that. There's numerous other large databases like that, and it illustrates that patients who had pre-existing chronic kidney disease are at much, and when they survive an episode of acute kidney injury, are at much higher risk for developing end-stage renal disease after discharge from the ICU. So they have to go to the hospital to receive chronic dialysis 3 times a week, or PD, etc., etc. A huge economic and social and toll for these patients. And this brings me to my last item I want to discuss on epidemiology, quality of life. And this is maybe a bit complicated graph. It's a graph using the short form 36 tool, and it classifies well-being according to a whole range of domains. And you and I hope, are having normal quality of life, and we will classify on all these domains at 50. So 50 is the gold standard. That's how we are. And as you can see, this is a study we did, but others have done similar studies, and it has been summarized in a meta-analysis very recently by Villeneuve and Sean Bagshaw. We saw that at baseline, our patients were, well, ICU patients have comorbidity, we know that. So baseline quality of life was a little bit reduced, but at 3 months and 1 year, we saw that there was reduced quality of life on several domains. And the 2 bars indicate AKI patients, the light blue, and the dark blue are matched ICU patients, and they are matched for severity of illness, age, etc., etc. And that's intriguing. So the quality of life on all these different domains in AKI patients treated with renal replacement therapy is similar at 3 months and 1 year in ICU survivors who had AKI treated with RT and ICU survivors who did not have AKI treated with RT. That's kind of counterintuitive. We thought these poor RRT-treated ICU patients, well, probably are doing worse on the long term. But that didn't show up. And interestingly, the emotional domains, the way patients thought about themselves, and the emotional domains, they actually were doing better compared to other ICU patients. And when we asked them, do you want to have another episode of ICU care if you're very sick, the majority, over 80%, answered yes. I do want to have another episode of ICU care despite this challenging episode I already had. And that was a kind of an eye-opener. We didn't expect that data. So this brings me to my concluding slide. AKI is very frequent. The very sensitive definition of AKI makes that over 50% of our patients have an episode of AKI, but remember, 1 in 3 has more severe forms of AKI, and 30% are nowadays being treated with renal replacement therapy in the ICU. Increasing severity stage is associated with increasing mortality. That's logical, I guess. Surprisingly, we found similar occurrence and outcome in different regions of the world. So it kind of made us think if AKI therapy is effective or not implemented. Well, that's kind of going back to the 0 by 25, and it's interesting to see what will happen next. I want to acknowledge all contributors to the AKI study, and it's in very fine print, but they're all on it. So thank you again for contributing to this great study. You've done a lot of work, and it was very much appreciated. And this brings me to my concluding slide. Thank you very much.